trustees of the PSP Association. I'm an orthoptist by background with a clinical interest in neurological conditions and their effect on eye movements. So just a few bits of housekeeping first of all, and then I'll introduce our speaker for the evening. So if I can ask everybody to stay muted throughout the session. We will be recording the session, and we can share the recording with you afterwards, but there are some videos that we will need to edit out due to consent. We will be transcribing the session and we'll share notes and slides following the session. Please can I ask that everybody attempts to have their name on the screen, just so that we know who is here today. And I do appreciate that some people are having some issues with changing the names on Zoom. So we will go through all of the questions at the end of the evening, but please do put your questions into the chat, and then we'll pick some of these for Jade to answer at the end. If we don't get through them all, we will try and get back to you after the session to give you the answer to your questions. And also just to remind people that this is an event for health professionals. We do have a number of people affected by PSP and CBD, and we're not able to answer individual questions, and they will need to go to their medical team for that. And we will be sending out some feedback following the feedback forms after the masterclass. So allow me to introduce the speaker. So we have Jade Donnelly speaking for us today. She's an APS coordinator and specialist physiotherapist at Southampton General Hospital. She qualified from Southampton University and then worked in Plymouth, completing her junior and senior rotations and specialising in neurology. She worked for the charity Scope prior to moving to Leeds, where she then worked as a private neurophysiotherapist for 10 years. And she was chair of the Yorkshire ACPIN prior to her relocation with her family to Hampshire. So she also has a coordinator role for the peripheral nerve service at the Wessex Neurology Centre and attends joint clinics with Dr. Gosh and Dr. Massey, as well as running her own clinics. And she provides advice and support to patients and carers and liaises closely with other services and professionals. So Jade has also spoken locally and nationally for PSPA, and she co-wrote our PSPA guidelines on physiotherapy and wrote a chapter on APS and Parkinson's disease, a multidisciplinary guide to management by Lindop and Skelly. She's heavily involved in research for both commercial and non-commercial trials, and is currently PI looking into movement in APS with the University of Southampton. So Jade, over to you.
Thank you for that introduction, Greg. Let me just get my screen shared.
Jade, you're on mute if you're speaking.
Can you hear me now? Yeah. Okay, let's try that again. So hopefully you can hear me now and see my slides. So my disclosures, I'm a member of the PSPA Services Committee. And these are the aims of this evening's session. And I think you've all had these. So it's to improve your clinical understanding of the mobility challenges in PSP and CBD, look at the practical skills to create individualized mobility interventions, and think about the impact of the progression of these conditions on how your therapy might change. So what is progressive supranuclear palsy? It's a neurodegenerative tauopathy, and we know the various areas of the brain which are affected. We know it progressively gets worse over time. There's an impact on there's a supranuclear impact, so we know that the nuclei that controls the eye movements is affected, and we know that it can cause weakness. So the average age for someone who gets this condition is 63 years old, and the incidence is 6 per 100,000, and the median survival is around 6 years. And we know it can take between 3.6 and 4.9 years from that onset of symptoms to diagnosis, which is quite a while. And I think that shows the complexity of how challenging getting a diagnosis is. And when these diagnoses are made, we want to be sure that we are giving the right diagnosis. So as I said, these are tauopathies. Now, we all have tau within our brains. It's normal to have tau, and that tau gives structure to the cytoskeleton. And what we find is that there's a buildup of tau, and the tau forms tangles and clumps, and then that causes microtubule disintegration and ultimately cell death in various parts of the brain, which then manifests as the symptoms that we see. So there are various different phenotypes of PSP. So we talk about PSP, and often when we're talking about PSP, we might be referring to the Richardson syndrome. But there are also other variations, other phenotypes, and there's pure gait freezing, and there's PSP-P, which is PSP Parkinsonism, which runs at a slightly longer trajectory. So it's just to be aware that there are different phenotypes. I'll be mainly talking about PSP Richardson syndrome when I'm talking this evening. Now, there are red flags to PSP, and these are important to be aware of, and these are available on the PSPA website. And so it might be that you're seeing a patient with Parkinson's disease, and you might be thinking it's slightly unusual because you might be seeing features that you wouldn't necessarily anticipate. So it's good to think about the red flags and what you're seeing with the person there in front of you. So this slide just gives you an indication of timescales for when we might see symptoms and their onset. So a walking aid might be required within 3 years. So when we're thinking about that diagnosis taking 3 years, they might be needing a walking aid by the time they're coming to see us. We know that swallowing problems can happen after about 4 years, and wheelchair dependency or patients being bedbound after 8 years. And if we think about the duration of the condition being sort of 5 to 10 years, we can see that that's in the very latter stages. So these patients can stay very mobile throughout the course of their condition. Obviously, there's variability, but it is something to be aware of. So what evidence is there for physiotherapy? Well, there was a study done in 2019 looking at a systematic review looking at all the evidence for physiotherapy and PSP in 2019, and it showed that there was some benefit to physiotherapy, but most of the studies were single case studies, so the evidence was poor in a way. But we do know there's numerous supporting papers looking at physiotherapy with Parkinson's disease and also the aging population. And we also know as professionals that there are huge benefits from remaining active, both physically and mentally. More recently, there have been some case studies in 2023, and again, they're case studies. There haven't been any big studies as far as I was able to see. But these really nicely describe the motor and non-motor symptoms and the physiotherapy intervention. And again, they show that exercise and physiotherapy are beneficial for those with PSP and can improve function and improve quality of life. Similarly, this was a single case study, but again, it was very good at describing what intervention was given. So they were provided with 15 hours of physical therapy, 1 hour out for 1 hour twice a week, and it broke down what aspects they were working on, and again showed benefit. However, when they went for review, there was a drop off as adherence wasn't maintained following the course of intervention. So we know from the evidence, there's limited evidence, but we know that therapy can be helpful. And what do we know from the patients? We know that the patients want to participate in exercise, particularly early on in their condition. But there is this message that maybe patients aren't being referred for therapy and they're having to seek it independently. There's also an uncertainty of what activity should these patients be doing and what is the most helpful? What dose should we be prescribing? And I think for carers, if they're looking to do this independently, it's navigating the system, which in itself can be really challenging and burdensome. Healthcare professionals believe that exercise is important, yeah? And we think it's beneficial for those living with PSP to live well. But again, there's this uncertainty over what to deliver and how to deliver it, and also that lack of evidence to guide. Similarly, this paper highlighted that physio was beneficial, but it also highlighted the need for better education between healthcare professionals, but also highlighted the need for education into managing these conditions and what is best. So if you think about the mobility challenges that we see in PSP, so we've got a video. I think another impact of PSP is obviously the visual component. So we know we have this gaze palsy, so eye movements up and down can be restricted, and laterally, horizontally, they can also be affected. But patients can also have diplopia, so double vision. And this is an image of what you might see if you've got double vision. And that's, again, going to impact on how you interact with your environment, how you manage your balance. Sometimes a simple eye patch can be helpful. Sometimes prism glasses can be helpful. And again, I'd encourage you to see the other masterclass that was done by Dom, the orthoptist from Plymouth, with regards to more on the visual effects with PSP and CBD. So this slide just shows you some of the things that you might consider. So thinking about the dark glasses, the top right image of the prism glasses, the PSP-A can provide those for your patients, or you can go and see an orthoptist. Yep, saying it right. Sorry, get my orthoptist, and they will be able to scribe and look at what would be most appropriate for you. And I think that's really important. We often refer on for that to make sure that we're offering our patients everything that they can. I think the other thing to think about with regards to vision is, due to that eye movement problems, thinking about the type of glasses that they have. Many patients, it's quite common to have bifocals, but if your eyes can't move up and down, that may not be so helpful. So thinking about single focus glasses. So if we just go over the things to consider, so thinking about movement and mobility, so think about that postural instability, that motor recklessness, that crashing down into the chair. Particularly, I think it's important to think about that when you're in clinic, the positioning of the chair that you're asking someone to sit into. What you don't want them to do is crash down into that chair and bang their head against the wall. So just being aware of your setup in clinic, or being aware of the setup at the patient's home. Being aware of the behavioural changes that can happen as a result of PSP. So patients can have apathy, and sometimes managing that apathy can be quite challenging. They can also be impulsive, and we see that, and that's often a common reason for their falls, because they get up and go. Despite knowing that their balance is poor due to their postural instability, the doorbell will go, they will get up, and they will fall down. And patients can have apathy and impulsivity. It's not either or. They can also be quite compulsive. So if there was something on the floor in front of them, maybe a speck of dust, they might bend down to go and pick it up. Bradyphrenia, so that slowness of thinking. So when you're talking to patients with PSP, there might be that delay in response from a patient. So I think it's really important that we give patients chance, time to respond. The information is there. It's just that retrieval that takes time. So just be aware of that. And often the conversation can have moved on, and then the answer will come in. And just being aware also that emotional ability might be a feature. With regards to bladder and bowel problems, we know that constipation, lots of things slow down in PSP. The bowels do too. Patients can also have urgency. And I mention that in relation to mobility, because if someone's rushing to get to the toilet, they might not think to take their frame. They just have the focus of getting to the bathroom. And again, just being aware of that and the impact of that on potential falls, or the falls risks, and how we might manage that. I've talked about the visual problems. I think something else to be aware of is the photophobia, so that light sensitivity. We've talked about wearing dark glasses, the blepharospasm, where the eyelids close. Sometimes you can touch your eyebrow, and that can help. There are certain tricks that can help open up the eye. If it's really intrusive and troublesome, you could consider botulinum toxin. And again, just thinking about the reduced blinking and making sure that maybe eye drops for the eyes, just to prevent infections, because often we can see the patient's eyes are streaming, and that's because they need to blink because they need that moisture. Also being aware the impact of fatigue and cramps and spasms might be something that we see. So I'm going to talk now about CBS, corticobasal syndrome. Similar prevalence to PSP, similar onset. Again, there's no curative treatment. It's a clinical diagnosis. The areas of the brain affected the basal ganglia and the cerebral cortex, and that then explains why we see some of the symptoms that we see. So similar to the red flags for PSP, there are red flags for CBD, and these are things to just be aware of, things that you might see. And these are the diagnostic criteria. So again, this information is all on the PSPA website. So I would direct you there for more reading. So things to think about with CBD, again, with regards to movement and mobility. So it can be asymmetrical. It might be a limb, an upper limb or a lower limb, or it could be both. We often see an alien limb phenomenon where the limb will do something all by itself. And that is not in conscious control of the patient. We also see apraxia and dystonia can cause some problems, but we will talk a little bit more about that a little bit later on. Similarly, there are behavioural changes, and again, bladder and bowel issues, and they can have a gaze palsy. They also have visuospatial difficulty, so organising themselves to get sat down in the chair, but also issues around maybe navigating around using a remote control for the TV, for example. So different things, subtle, there are differences between the two and things to be aware of. So thinking about the practical skills that we need as therapists when we're working with patients with these conditions, I think our observational skills are really, really important. And I think as physios, that's what we're used to doing. We're used to looking, analysing and seeing what's going on to then think about what we're going to do next with the patient, working with them towards the goals that they want to achieve. And I think this is just a really lovely description that Charles Dickens wrote about someone with PSP. And I'm just going to draw your attention to the last bit. He came in and shut the door and now sat down. He did not bend himself to sit as other people do, but seemed to sink bolt upright as if in water until the chair stopped him. And I like the description of the way it says the chair stopped him. So often we see that crashing down into the chair. We don't see the normal biomechanics of stand to sit, sit to stand that we would see without this condition. So we know that patients with PSP have falls. It's a cardinal feature of the condition, and we know there are many reasons why they might fall. And some of those reasons are listed there. Freezing of gait is one of them, that bradykinesia, the axial rigidity, so that stiffness and movements around their trunk, and those postural instability. So Brown in 2020 highlighted that frequent fallers have often been found to have disproportionately poor performance on turning and pivoting. And I think there is a difference between the way in which Parkinson's patients move and patients with PSP move. I think it's really important to think about backward chaining and think about incorporating that into the therapy that you're providing for these patients. If we know they're going to fall, I think it's helpful to be able to teach them how to get up off the floor safely. I also think it's worth looking at the way in which patients turn, so we know that they can pivot on that spot. Can they do a sidestep or do a wide arch turning round? So thinking about the way in which we're helping them move, and again, thinking about the aids that you might give them to help with that. So stairs, stair lift and single level living. I think it's worth thinking about the stairs. We know patients have postural instability, and therefore stairs can be a little bit risky. We know that mobility can get more challenging as the condition progresses, and this is worth considering for both PSP and CBS. I think if patients are going to go with a 3-floor lift, I think be mindful that they get it big enough that it will take a wheelchair. We've had a case where they independently went and got a 3-floor lift, which would accommodate one of them standing, but it couldn't fit a wheelchair in. It's a huge investment, so you want to make sure that we're advising those under our care and services so that they have that future proofing. Stair lifts, again, just be mindful of the impulsivity. I think you have to assess it on a patient by patient basis. If you know a patient that's going to get up impulsively while they're sitting on a stair lift, you just got to think of the risk associated with that. So I think there's lots of options out there, and I think you've just got to think about the patient there in front of you and what would be most appropriate for them. This study looked at gaze control and foot kinematics in relation to the stairs and the impact of trips and falling. I think we need to think really carefully about the stairs. Stairs can be a risky environment. Patients often want to keep going up and down the stairs, and carers are very happy to support them doing that. But there are risks associated with that. And I think it's fine if the patient and the carer fully understand those risks. But I think it's really important that we highlight those risks. I say that because we've had patients that unfortunately have fallen on the stairs, some with minor injuries, but there was one case where the patient fell, took out the carer as they fell, and sadly the patient died, and the carer sustained life-changing acquired brain injury. So the risks are real, but I think you just have to assess it on a patient by patient basis. And many patients manage the stairs for a long time into their condition, but you just need to be mindful of the risks and be sure that the patients understand the risks associated with the stairs. There are papers, this paper by Zamparini looking at balance and eye movement training. And again, I think it's worth thinking about that and how you might incorporate that into your therapy. Thinking about mobility aids, I've touched a little bit about laser canes. Think about the U-steps. The U-step was designed for patients with PSP. It pivots on the spot. You can have auditory cueing and a laser beam put onto it. They are pretty good. You can hang on them and they don't fall over, but there are lots of walking aids out there. So think about what would be most appropriate for your patient. Sometimes grab rails on the wall are more effective. Sometimes patients prefer holding onto someone's arm. So think about what is most appropriate for them. I think thinking about sit to stand, the biomechanics of sit to stand, I really like to work on that sit to stand and that exaggeration of that trunk forwards for that hip hinge, and using that momentum to help with sit to stand. Working on balance, I think, is important. And again, as I mentioned previously on one of the other slides, thinking about that step standing position, that power stance. If you're thinking about patients opening up the fridge door and as they take their weight backwards, are they just going to fall backwards? If they're in that power stance, might they be more stable? Can you look at the way they do some functional tasks and make it a little bit safer for them? We may not be able to reduce all the risk, but we might be able to minimize it. And think about bed mobility. I think due to that axial rigidity and that stiffness in the trunk, bed mobility rolling over in bed can become really challenging. So can we incorporate those rotational twisting movements to help them with bed mobility? Again, not forgetting postural management and thinking about their posture when they're eating and drinking, but also being aware of retrocollis that we often can see in patients with PSP, and that's that moving back of the neck, tipping it back, and it can be quite restrictive and has a knock-on effect to eating and drinking as well. And think about task-specific exercises. I think, it's worth thinking about what activities you're doing and what would be helpful to the patient. So last week I did a teaching session down in Hampshire, and I was delighted to have Laura from Neuro Heroes come and join me. So Neuro Heroes is an online exercise class for people with PSP and CBD. And this is a write-up about it in PSP Matters, so I'd encourage you to read that. There's also a podcast that's definitely worth listening to. So the exercise classes run over 8 weeks. There's a session each week. It's all funded by the PSPA, and this is a 4-year project, and I believe we're 2 years in. It's all on Zoom, so the patients don't have to worry about going somewhere, and they give you lots of support and setup with Zoom. I think when I first heard about this, I was quite concerned about the falls, but actually having listened to Laura talk about it, it's managing that risk assessment. These patients are going to fall. They are potentially going to fall, but with you there on the end of the screen, you can help manage that, or you can respond to it. And I know they've had some falls during their lessons, but the patients that have fallen, I think all but bar one have got up and carried on with the session. And the feedback from these sessions, it was really lovely looking at the feedback and I was sort of, thank you, Laura, for letting me share your slides. Patients really, really enjoyed these sessions. It gave them confidence. They gave them a sense of achievement. There are some lovely feedback that she received. And also from the wellbeing scale that they used, it also showed that their wellbeing had also improved from participating in these exercise classes. So as the disease progresses, we're just going to talk about progression now. But I first want to consider what happens if patients receive little or no therapy or experience periods of inactivity. So hospital-acquired deconditioning is widely documented, and we know there are various factors that impact on it. This was a study done by Smith et al. In 2020, and it highlighted the many different challenges and the multifactorial problems that healthcare professionals face when managing these conditions. And it made us think about our patients with atypical Parkinson's syndrome. So we did a retrospective study looking at accelerated deconditioning from prolonged bed rest without mobilization in APS, really highlighting the importance of early mobilization in deteriorating conditions. And so what we found, and I acknowledge it's a very small study, is that there was a really big noticeable change in the PSP patients. The patient came in mobile, and on discharge, they required a hoist. So that's a huge change in their functional level. And we use the PSP rating scale, so the PSPRS, and we usually measure that annually, and it's a very accurate way of measuring disease progression. And we would anticipate a 1-point change every month, sort of averaging 10 a year. And in this case, the score increased by 19 points in a 14-month period, which is huge. So I acknowledge that this is a small study, but I think it really highlighted the vulnerability of these patients to deconditioning. And there are many reasons why patients decondition, but what can we do to help manage it? So time is function. So this is a schematic from that paper. So if you think about a patient being admitted, if we're prompt and we get physiotherapy intervention in there quickly, they can maintain their level of independence. If there's a delay, they may get back to their level of independence, but there will be a deterioration in their function. And if we're really late with therapy starting, they won't get back to that level of independence. So thinking about these patients and how we might manage that. Certainly when we have patients that are coming in maybe for a gastrostomy, we try and plan for that. It might be that the carer comes in with them. We try and make sure the ward are aware of PSP and the challenges patients might face, to help try and reduce the risk of that deconditioning. And that's on a planned admission. Often admissions aren't planned, and it's how we can think about raising awareness about these conditions so that we can manage it as best we can. So we might want to think about the equipment that we use and is required. So thinking about beds and sensors. So patients can be impulsive, they can get up frequently. If patients are getting up lots and lots during the night, that can be quite challenging to manage. Sometimes having a bed that goes down much lower means that the sensor can be triggered, so then someone can come and help them get out of bed to try and reduce that risk of a fall. Sensor mats are helpful, but they're only as good as the person that's going to respond to them, so it's worth being aware of that. So I talked about dystonia earlier and managing dystonia, and we know that can be a problem with CBS, and we will work closely with our occupational therapy colleagues to think about how we might manage that. So we might use splints. We might consider botulinum toxin. Most of the evidence says there's not going to be functional improvement from using botulinum toxin, but it can help with pain and hand hygiene. There are various splints out there, and thinking about how you might use those to help limit contractions and the potential for skin breakdown. So other things to think about is a wheelchair. Again, thinking about wheelchairs and a timely referral. If posture and postural management is challenging, thinking about sleep systems. There are various other bits of equipment that you could consider. Sometimes a shower chair that's got tilt could be helpful. There are some nice chairs by Seating Matters. This is, I think, the Phoenix or Sorrento. Another T-roll, for example, that might help with postural management in bed. Riser recliners can be really helpful. I think the key thing with riser recliners is use as little of the rise that you need so that the patient's still using their muscles. And it might be that they're very fatigued at the end of the day and therefore they need to use more of the riser recliner. I think we want to try and steer away from using rise when we don't need to use rise, because we want these patients to use their muscles and have that activity to help with sit to stand and use their muscles. So if you have a little look at this slide, it looks at the progression of the condition with regards to cognition, ocular motor function and motor function. And there are various stages. And if we think about that early stage, we're thinking about working on balance, we're thinking about working on strength, we're thinking about looking at backward chaining, task-specific exercises. And again, we want to be touching on future-proofing education advice for the patients and for the carer. And in that mid-stage, that's where it can become quite tricky managing that impulsivity and managing safety. There might be carer strain, and that's something to be aware of. And again, we still want to be thinking about future-proofing and planning ahead, and again, providing education and support. And in the later stages, our role may be more towards postural management and quality of life. But at all times, providing that education and advice and support for both the patient and the carer. Other things I thought might be helpful to just think about is blue badge applications. So often our patients are mobile, but it's that risk of falls, that motor recklessness, the impact of vision and the impulsivity, the things I would draw out if I was writing a supporting letter for a blue badge application. Similarly with CHC, there's some fantastic information on the PSPA website. I think CHC is really challenging. I think my key bits of advice would be keep a diary and don't underestimate what family members are doing and the complexity of some of the care that they provide. Highlight some of the hidden symptoms and the complexities of these conditions, so the risk-taking. Evidence is key, so be descriptive, be explicit in what you're saying, and really highlight that well-managed needs are still needs, even if those needs are being met. I think it's increasingly hard to get CHC funding, and I think there's a bit of a postcode lottery, but I think we want to do as much as we can to help try and support our patients in going through the process, because ultimately you only really want to go through that process once, because it is really, really challenging. I'm just going to finish up with a case study, and this patient had actually MSA, but I think it's still very relevant in the context here. And I received a call from a family member saying, Jade, I'm not sure what to do. We've got care coming in 4 times a day. He was walking a couple of weeks ago. Everyone's saying it's the condition and it just doesn't feel right from what you've told us. These conditions don't change overnight. You're not going to see a sudden change. If there's a change from being mobile to immobile, you've got to think about something else going on. Is there a UTI? Has something happened? And in this case, this patient had had a fall. If you look at the CAT scan, maybe spot the problems there. So they had bilateral subdural hematomas, they had burr holes, and he went on and had rehab and did well from that rehab. And the reason I mention this case is because listen to your patients, listen to those carers. And although you may not know all the ins and outs of these conditions, they will progress at the rate they progress. They're not going to change suddenly overnight. So if something has dramatically changed, there'll be another process going on. And all too often, when you've been given a diagnosis, everything then gets pinned on that diagnosis. And I think we need to advocate very strongly for our patients to support them in that in the community. So in summary, there is no cure for these conditions, but I think there's plenty which we can do to offer support and try and improve the quality of life of those under our care. I think physiotherapy has an important role in the management of those with these conditions. I think early intervention is key. I think proactive management and future-proofing, and as always, more research is needed. Thank you ever so much for listening.
Thank you, Jade. That was great. That was really good. There have been lots of really positive comments in the chat. But do you mind if we go through a few questions, if you've got a bit of time to go through some questions?
Yes, sure.
So the first one that came up was, do tau proteins show on a DAT scan? And if someone has negative DAT scan, so i.e. no diagnosis of Parkinson's disease, could they still have PSP?
So tau doesn't show on a DAT scan. I think we're not there yet. They're looking at biomarkers, but we're not there yet. There's lots of really exciting work being done by Ed Jabari and Hugh Morris and the Prospect study, but no, we're not there with a biomarker yet. DAT scans provide information, but it's a clinical diagnosis.
Thank you. There was one comment when you were showing the videos of the of PSP and CBD and comparing the two, and there was someone who was saying that looking at these videos, they're convinced that a patient of theirs has CBS instead of PSP. Would the treatment approach be different for the two conditions?
So you can have PSP and CBS overlap, so they may have one and have an overlap. For both, there is no cure, and your management would be similar. So I think, although the diagnosis, there might be some question over it, I think your management is going to be very similar, and you're going to be thinking about that current treatment and then future-proofing.
Perfect. And then there was a question around, do you have any tips for supporting patients to get a diagnosis? They previously had a client with multiple red flags, including a vertical gaze palsy, but they were being dismissed as anxious or patient was functional by general elderly care doctors.
So I'd encourage the GP to maybe refer into a specialist centre. I don't know where this person is in the country, but there are various specialist centres that they can get referred into where they've got maybe more expertise in these conditions. Patients are entitled to a second opinion. We often have patients travelling a long way to see us in Southampton, but London has a big centre, and there's a big centre in Newcastle, and I think there's another big centre in Wales. But there are centres around where movement disorders there are maybe more specialism within that it might be worth referring into.
Thank you. I think someone's sharing their screen. Hold on, let's stop that.
Oh, I'm Bristol. Yes, thank you. Sorry.
And someone has asked if there are any further research is there any further research for these patients in the pipeline?
So there's lots of research going on. And again, I think the PSPA have done some great talks on research. There's research looking at halting the progression of the conditions. There's various studies going on at the moment. We're part of the PROSPER study that I think has just closed to recruitment, but that's ongoing. There are other studies in the pipeline that are coming up. There's always new studies coming along. At the moment, I think due to the there's more studies in PSP than there are in CBD. But there are also quality of life studies. There are looking at, my studies looking at movement in these patients. So there are lots of different studies that patients can be part of. And again, I'd really encourage, if you have patients that want to be part of research, if they come in via the PSPA, they can direct them to the centres that have active studies going on that they can be part of.
And do you see much carryover between sessions, for example, sort of from to stand training?
Yeah, I think there's carryover. I think it's reinforcing as well. So I think for those patients who have a caregiver that can reinforce the message and practice and repetition, I think that's helpful. I think the challenge comes for those patients that live on their own. I think that's, that could be really challenging when they haven't got that person to give that ongoing prompting and support.
And then, what is your view on use of dopamine replacement therapy in PSP and CBD?
So we often do a trial of levodopa in the early stages. They may have a response to it. If they have a dramatic response, we might be questioning the diagnosis, but they may have a response to it and might be helpful. Some patients do stay on it that little bit longer because they feel it gives them a little bit of help. We don't see the dramatic changes that we'll see in Parkinson's disease. We might also try maybe amantadine. That can have a bit of a livening effect as the condition progresses. It might give them a few more words, a bit more speech. So there are medications to think about in the symptom management.
Perfect. Thank you very much, Jade. I think that's all the questions that I've managed to pick out from the chat as we've been going through. So yeah, thank you ever so much, Jade. That has been fantastic. And thank you everybody for coming this evening and for giving up your evening to attend this masterclass.
Thank you ever so much.